On behalf of the Duke Margolis Institute for Health Policy, I'd like to thank everyone for joining today's webinar on scaling primary care for high-need older adults, building a home-based medical care ecosystem. We're very excited to host today's webinar on this important topic during a time when the policy landscape is evolving, but the emphasis on strong home-based primary care remains as strong or stronger than ever. It's been nearly 60 years since Medicare was enacted, and the program looks very different today than it did in its early days. Today, Medicare Advantage plans now serve a majority of the Medicare eligible population and are continuing to grow, along with more integrated duals plans at the federal and state level. Also, about 13 million traditional Medicare beneficiaries are in accountable care arrangements like the Medicare Shared Savings Program and ACO REACH. At the same time, as these programs move forward, there's continuing need for payment and policy reforms to meet the needs of an increasingly aging population. About 10,000 people are entering Medicare every day. And despite efforts to improve primary care and home-based primary care services, there remains a mismatch between the supply and demand of needed care. The number of Medicare beneficiaries who are homebound has more than doubled since 2011, totaling an estimated 4.6 million beneficiaries, but only 12% of completely homebound individuals receive primary care in their home. And that's not to mention the additional Medicare beneficiaries and their caregivers might prefer to have care delivered at home. Accountable care arrangements have been tools that seek to align payments and supports with what people need at the whole person level to help meet patients where they are and where they'd like to be, including getting holistic primary care services all together, chronic care management, care coordination, addressing health-related social needs and other non-medical drivers of health, all to help keep people in the home to keep them well. However, the value-based care or accountable care arrangements for home-based care are still the stage of scaling up with a long way to go. Many home-based primary care providers are smaller, independent practices. These practices have faced challenges in engaging accountable care models in terms of resource constraints or the technical issues involved in meeting the conditions of a payment model. Support organizations for home-based primary care are growing, but not fully integrated with many of the providers and other services needed to make care work at the home. As you may know, the Centers for Medicare and Medicaid Services over the past two administrations has been committed to helping all Medicare and most Medicaid beneficiaries have access to coordinated longitudinal person-focused care, including care in the home if they prefer it, through accountable care relationships by 2030. Achieving this goal still has a ways to go. It will require increasing engagement of diverse provider groups, including home-based medical care providers in CMS's accountable care models to support longitudinal care for older adults and beneficiaries who are homebound. It will require more steps to increase access and engagement of the technical support, coordinated care services that often work with primary care practices or health plans to deliver more holistic care in the home for the people who need it most. Building a home-based medical care ecosystem remains a big and ongoing undertaking, but it is a good time to build on the existing efforts. For example, CMS just released performance results for the ACO REACH model for 2023, where a number of participants are supporting significant home-based primary care. We've seen positive results on that in that model, particularly for the highest risk, complex Medicare beneficiaries in the program. So to take all of this forward, we have a fantastic panel today. They're going to explore some short-term practical policy opportunities, as well as longer-term opportunities to build a home-based medical care ecosystem. Now, before we hear from our panelists, I want to thank the supporters of this very important and timely work. The project and today's workshop are supported by the John A. Hartford Foundation, which is dedicated to improving the care of older adults through evidence-based healthcare. And in particular, I want to thank Ronnie Snyder, Vice President for Programs at the John A. Hartford Foundation, for being with us today, and I'd invite her to share some remarks now. Ronnie?
Thank you, Mark, for the welcome. Hello, everyone. I'm Ronnie Snyder. I'm the President for Program at the John A. Hartford Foundation. And I want to thank the Duke Margolis Policy Center and all of you who share my enthusiasm for creating an ecosystem, really, that can support age-friendly, home-based medical care for older people who have complex needs. The John A. Hartford Foundation is a national philanthropy. We happen to be based in New York City, and our mission is to improve the care of older adults. So we do that by working in three very much overlapping priority areas: creating age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. And we support the Duke Margolis Policy Center and other grantees that include the Home-Centered Care Institute, the National Learning Network for Home-Based Primary Care, and the American Academy of Home Care Medicine, all of which then work together to promote home-based primary care for older adults. They can help you and your health system as well to adopt or improve your home-based primary care. And we hope you will use the educational and training programs that they all, as a collective, offer, which are really fantastic. So that work is one part of our effort to spread age-friendly care, which is care that is evidence-based, that reduces harm, and that is completely aligned with what matters to each of us, to each older person and our family caregivers as we age. So for a lot of older people who live with, let's say, complex conditions, especially those who may be homebound or home limited, what matters often includes simply getting access to care that meets them where they are, that's delivered by teams that listen and respect their goals, their values, and their preferences. And our work in home-based primary care is also complemented by a variety of other home-oriented programs, including, for example, hospital at home. There's a continuum of this kind of care, right? Hospital at home is a model for delivering acute level care for certain conditions where an older person lives. And we fund other initiatives that advance policies and programs that support both family caregivers and direct care workers who are essential to helping all of us age in place. All of our home-based care work also aligns with our age-friendly health systems movement, which centers on what we call the 4Ms framework. The 4Ms are an evidence-based set that focus on what are really the most important predictors of good health outcomes for older people. They include addressing what matters, that's the first M, to the older patient and his or her family caregiver. Medications, so ensuring that they are safe and deprescribing whenever possible. Mentation, which is anything cognitive, so screening for and treating the cognitive issues like dementia, delirium, depression. And last but not least, mobility, ensuring that older people are supported to be as physically active as possible to preserve function, even if that's limited and only in the home. Mobility still matters. The 4Ms framework is based on evidence from geriatric care models that produce the best possible outcomes. And we encourage every one of you to join the age-friendly health systems movement if you haven't already. That's whether you work in home-based care, in hospitals, in nursing homes, or really just in any setting. Could be a convenience care clinic, could be anywhere. And if you want to learn more, you can check out our website. This is going to be a really rich discussion about the current landscape of the field, including recent research, identifying barriers to scaling home-based primary care, and exploring opportunities for health policy leaders. So I want to thank Rob Sanders, Frank McStay, Montgomery Smith at Duke Margolis for their awesome work on this project. And I will turn it back to Mark, who we also thank for his leadership. And we really look forward to learning with all of you today and to continuing to support you and your home-based primary care journey.
Ronnie, thanks very much for joining us. And now I'd like to introduce Frank McStay, Assistant Research Director at Duke Margolis, to moderate this important panel discussion on building a home-based medical care ecosystem to meet the needs of high-need older adults.
Great. Thanks, Mark. And thank you all for joining us today. I think Mark and Ronnie's comments are better than I could have done in terms of teeing up for our conversation today on scaling primary care for high needs older adults, understanding that ecosystem that needs to be in place to make sure that those providers are supported in meeting the needs of those patients who are homebound. Like Mark said, I think it's important to acknowledge we have over 10,000 people retiring into Medicare daily, and a significant and growing proportion of them are homebound. Over the last 3 years, Duke Margolis has been exploring the home-based care space, exploring those policy actions as well as those payer and provider supports that are necessary to spread what Ronnie calls that age-friendly care system. During this webinar today, we're going to take a deep dive on many of the topics we've learned about over the past 3 years. But really, again, today's a conversation where we hope that we can all learn from each other. I'm deeply appreciative of the almost 200 people who've joined us right now in real time, but also the over 250 other people who have registered for this event and are likely to watch the video at the end of today. To that end, I'm really just going to be a facilitator for today, and I'm going to stop talking and instead ask my panel to join us and turn on their cameras and microphones as I introduce them for a really rich discussion. So to kick things off today, I want to introduce first Dr. Tom Lally. He's a dedicated house call physician and CEO of Bloom Healthcare, an employee-owned primary care physician group that specializes in providing home care to older adults. He is founder of Physician House Calls, Bloom Healthcare, which has been at the forefront of delivering coordinated exemplary care for geriatric patients for over 2 decades. Next on my list is Pauline Lappin, who is the director of the Seamless Care Models Group, or SCMG, at the Centers for Medicare and Medicaid Innovation at the Centers for Medicare and Medicaid Services. She's overseen and provides guidance on the development and implementation of innovative payment and delivery models related to advanced primary care and accountable care organizations, including the ACO REACH program. Jason Resendez is president and CEO of the National Alliance for Caregivers, where he leads research, policy, and innovative initiatives to build health, wealth, and equity for America's nearly 53 million caregivers. Jason is a nationally recognized expert in this space, including caregivers, aging populations, and research and equity. Finally, and absolutely not least, Bill Rout, Director of Strategic Initiatives or Strategy at Highmark Health, where he focuses on maintaining and shifting care into the home for members and patients. He leads strategic planning and execution of a portfolio of business that really is about delivering the care in the home and enablement of home-based services across a diverse population. So with that in mind, and now that everyone has joined us today, I think where I want to tee off this conversation is by first acknowledging and building on the care that's already being provided in the home and the community. There is a lot of good work we can build on, and we want to keep today's webinar solution focused. And I think the perfect place to do that is level set on what's already going on at your organizations in terms of providing care to those high needs, homebound older adults. So maybe what we can do first is, Tom, kick off with you. I know Bloom Healthcare, like I said, has been involved in this space for over 2 decades. So can you kind of speak to some of those common care needs for this population, and what you guys are doing at Bloom Healthcare?
Thanks, Frank. And yeah, I think it's a great place to start is what this patient looks like, because it's not a typical retirement patient. It's not somebody who just generally turns 65 years old. It's generally almost a super senior. It might be their parent. So our typical age of a patient getting home-based primary care is well into their late 80s. They're generally in their last 3 years of life. They have that common, to what Ronnie said, there's a commonality among them that they can't access the care they need. So even if they can get out to see a primary care physician a few times a year, it's not at the frequency intensity that they need for themselves to be able to age in place. So really, home-based primary care, it's for patients who need house calls, not for ones who want a house call. And so this is really designed for those multi-complexity patients who are living in their home and really seeking to age in place. There's an extremely high incidence of dementia. Almost 65% of our patients who we care for inside of the home are home limited, and because of that cognitive issue. They can't travel safely. They often need 1 or 2 others to be able to get them to their appointments. And so they become increasingly isolated until an emergency happens. There's also a high proportion of patients who are dually eligible. These are patients who generally are underserved in both rural and urban areas and are really needing access to come to them. And it really aligns very much with, once you think about this population, it is a very, very high needs patient population who can't always advocate for themselves. They have limited networks of people around them to often help them support. Oftentimes friends and family, neighbors may even have passed. And so the care model really has to fit that type of patient. So we think about very small panel sizes. Our providers throughout home-based primary care really have a very high visit frequency when they see their patients, oftentimes once or more a month. And that's going to allow them to see a very few number of patients a day, but a lot more time with each patient. And that's one of the key things, that they're going to be able to build trust in a living room. So having those shared conversations with decision makers right there where the patient is living and aging in place is incredibly important. And it comes to that empanelment that we need. It also has to be risk stratified. One size does not fit all for this population. High needs patients still have a varied needs and supports, and we really need to take that into account, whether that's social needs, different economic factors that they have, different social supports that they might have from their family or not, have to be incorporated into the plan of what matters most to that patient. If we come up with a one size fits all, it generally doesn't have the impact we want. It's also got to be very heavy on care management. No matter how frequently we see a home-based primary care patient, maybe see them twice a month, that still leaves 28 days in the month we didn't see that patient. And so we have to be thinking about proactive care management, and whether that's nursing, social work, pharmacy, others, but that empanelment where, again, you're getting to know somebody on the phone, you can call them anytime. And really, not only they know that you don't call on Monday for no reason, they recognize when you call on Monday, this is a very serious problem and they need to get you an appointment right away. But it also builds the trust between the patient. They know that, hey, they can call us and we are going to pick up the phone. And it gives them that other option towards 911, where oftentimes that was the only option they had in their toolbox before that. And I'd say the last part, and I kind of talked about this, it's really interdisciplinary. It cannot be done by a single provider or a license type. We need an entire team, which is why it's not appropriate for patients who just want a house call potentially. It's a very expensive way to care for a patient who doesn't have high needs, but it's a very efficient way to care for a patient who does have high needs and is not accessing the care they need.
Thanks, Tom. And I think that actually tees up Jason nicely, because marrying two things you said, and thinking about, again, this landscape of what is currently happening right now, Jason. So Tom talked about care management and this team. And I know caregivers are really important in this team for providing care for adults in their home. So can you talk to us a little bit more about your perspective in the landscape and kind of that important role that caregivers give?
Yeah, absolutely. First, thanks for having me and incorporating the caregiver perspective into this conversation, because as Tom pointed out, it really does take a team to adequately serve and support folks within home-based care. And family caregivers are often the most under-supported parts of that team, yet they're vital to providing quality home-based primary care. They support daily health monitoring, medication management, and early detection of health changes, the kind of support that reduces hospitalization and emergency department visits. They bridge critical communication between healthcare providers and patients, particularly for those with cognitive impairments, by relaying symptoms, side effects, and concerns that patients may not report themselves. Their assistance with activities of daily living and instrumental activities of daily living enable older adults to age safely at home despite functional limitations. At the same time, our research finds that 60% of family caregivers perform complex medical and nursing tasks as care increasingly shifts from acute care settings into the home. However, a concerning gap exists. 70% of family caregivers have never been asked by a healthcare provider about their support needs, and only 13% receive inquiries about their self-care needs from a healthcare professional. So there's a significant disconnect between the current role of a family caregiver within home-based care and the kinds of supports and formal engagement of family caregivers when it comes to integrating them into providing home-based care in a consistent and sustainable way.
Thanks, Jason. And I think rounding out this landscape with a payer perspective, Bill and Pauline, Bill, maybe we start with you. Again, it takes a team, and the payer is part of this team. Let's talk a little bit from your perspective about how we can better leverage the existing resources that are in place and what you guys are kind of already doing to meet the needs of your members.
Thank you, Frank. So I think one of the things that we've been thinking about from a payer perspective is there's a lot of care that happens in the home today. So whether it's traditional home health or home infusion services or community-based palliative care programs, and even HME, which is sometimes not clinical, but they're in the home with eyes on that member or that patient. I think one of the things we're looking at is how do we better create access to these services and how do we better integrate these kind of ancillary services into the core care paradigm. So one of the things as a payer that we can do on this front is helping to align value-based reimbursement across the different care modalities and care sites, aligned with shared goals and outcomes for that member or that patient. And then also, how do we help reinforce the need for care coordination and data sharing back and forth between all of these different providers that may or may not be in the home. And then lastly, thinking about what Jason said is, how can we help support those family caregivers, or how can we help support a member where they don't have a caregiver and that's a barrier to even accessing and staying in their home?
Yeah, thank you, Bill. And Pauline, now turning to you again, rounding out this payer perspective. I know CMS, 10,000 people are retiring into Medicare every day. It puts a lot of onus on you in terms of meeting those needs, but you guys have already done a lot in terms of how you're addressing those unique needs for this aging population, especially those that are homebound. So turning to you, can you give us a little bit of a flavor about what those programs are that are meeting those needs and how you're trying to maybe expand on them a little bit?
Sure. And I would say, just to echo what Mark said earlier, there has been an evolution in Medicare payment to mirror the growth in the aging population. We know that beneficiaries want to stay at home and they are living longer with multiple chronic conditions. And so one avenue where we have seen change is in the Medicare payments through the Medicare physician fee schedule, through more flexibility around using home as place of service, including assisted living as a home for place of service, and other group homes and other types of place of service where people live. We also have seen new codes added around caregiver training services that allow for people who are taking care of these very ill beneficiaries to have some training in the home so they can better support the needs of those family members. I would also say that we learned a lot about care in the home through the pandemic and the telehealth flexibilities, which have been extended through the end of the year and will continue in a limited fashion after this year, have also recognized home as an originating site. So there has been, more just through the Medicare program as a whole. The other avenue, obviously, is through our value-based care initiatives and models. And you mentioned ACO REACH, and Tom and Bloom Healthcare are participants in ACO REACH in our high needs ACO track. And we are learning a lot around the care that is delivered through that track in terms of what's needed to support providers and team-based care. And I think, Tom, you touched on a lot of that. Another model that we recently launched is the guide model. And I'm really excited about this because it's the first time that we are supporting caregivers with payment for respite care too. And also focusing on a very serious illness, and that's dementia. So, I think we'll learn a lot from that model as well, in terms of how we deliver care for that very vulnerable, ill population in the home.
Yeah, thank you all. And I think trying to tie this all together a little bit, I heard a lot about the complexity of this patient in this population. Both Tom and Pauline kind of hit on that it's not that they're just homebound, but I was actually talking with someone the other day about this webinar and noting that these patients often have multiple chronic comorbidities, that access, sure, maybe they get there a couple times a year, like you're saying, Jason, but is it the frequency or the duration that's needed? And then how, Bill, as a payer, can you make sure that all those services and that you can wrap around the patient totally? And so with that in mind, now that we have this kind of landscape of what we're doing now, I would like to kind of build on those kind of existing foundational blocks that we've described. In keeping this webinar solution focused, would like you guys kind of all weigh in from your different organizations and perspective about what that opportunity is for scaling these models. And so I think we all understand the needs are there. And we have made some progress to date, but would love to hear from you guys about what those near-term opportunities are to what Mark was saying in his kind of opening remarks, that we see a lot of progress in reach. I know, Bill, you mentioned some of the programs you guys have. Bloom Healthcare is a wonderful organization that has made progress too, not just in reach, but more nationally in terms of its program. And then also, Jason, I think caregivers and guide, again, we see this kind of role, this emerging importance of caregivers being placed into models. And so wanted to talk about what other opportunities there are to continue to build and scale on home-based primary care. And so, Tom, maybe turning to you first, what are the supports that are needed to kind of build this model more generally? What are those kind of near-term things that we could potentially focus on from a policy or a payment perspective to get you the tools you need to build it up?
Sure, that's a great question, Frank. And reimbursement is the number one thing. And I think we've seen a lot of change in how things are paid. And I think accountable models really fit this type of care much better than fee for service. And I think what we see among commonalities of like top performing home-based primary care groups is that they are primarily being reimbursed through accountable means, whether it's a shared savings, accountable care, but some sort of shared risk where they're really aligned incentives. I think for us, seeing the ACO Reach High Needs being a dedicated track from the Innovation Center was incredible, because it was the first time we ever saw a track that really was purpose built for this type of population. And we think that's an important ingredient, and to be able to scale this is to have a program that is really defined for this type of population, because we don't fit in a normal healthy bell curve. Our patients are the most expensive. They're the most outliers. And having something purpose built for that group, I think, is the most important part. I'd say the other thing that we have to think about is a trusted and trained provider workforce. We are taking on a new challenge where these patients are very complex. The average number of medications, maybe 10 or 12 medicines. They have 3 years of life to live. They've got 7 or 8 competing chronic health conditions. And we don't necessarily have the workforce that is trained to be able to manage that population. So a lot of our organizations are building additional training and thinking of ways to be able to work with university and academia to really be able to have that workforce that is prepared to be able to take some of these challenges on. But I think that really kind of comes very closely with reimbursement. As reimbursement changes and this becomes a more sustainable area, I think we can make more purposeful investments around the training and dedication of the workforce for the field.
Yeah, thanks, Tom. And I think that leads nicely into a question I was going to tee up for Bill. Bill, obviously, again, we want to keep it solution focused, acknowledging the problems, especially payers have with potentially finding workforce, that network solution of finding home-based care providers that are doing this or can do this. And there are a lot of other challenges too, data sharing and just kind of those capabilities of scaling these programs. I would love to hear from you as a payer, Bill. What's that one lever potentially that could be pulled that would really kind of set this off and catalyze change, that would allow for scaling and make it more comfortable for payers to really embrace this model, so to say, and give the payment that Tom was alluding to up front to, again, set this off?
Yeah, I think one of the things that we see is that, these models are successful. Especially when you get people into a value-based agreement, they're able to manage this population. One of the things I think we haven't seen yet is the full broad scale to cover multiple states, multiple geographies, rural versus urban. And some of that goes to what Tom said, is that, there's a overall shortage of care providers, whether it's in home or in the hospital system. But there's also even a bigger shortage of that skilled care provider that Tom talked about, with the experience to go into the home to manage this population. And we hear those pain points both from our internal programs as well as our partnered programs. But trying to get to, that's a long-term solution to kind of build out that workforce as this continues to grow. I think really the short-term opportunity is how do we optimize the right care at the right place at the right time, and leveraging that stratification that Tom talked about and the data and analytics there need to make sure we're providing care in the home, but also integrating that with virtual and digital options, as well as in person in the physician practice. And then, as I kind of spoke to in the beginning, is how do we leverage these other care providers that are also out there able to help manage this population? Because it's not just one person or one team, it's all of them coming together. So really think that stratification is kind of that next quick lever to get people the right care at the right time.
And I think that feeds nicely, Jason, team, again, like coming back to this caregiver idea that there's a lot of different provider types that are part of this. There's obviously primary care physicians and nurse practitioners kind of involved in this, or community health workers. I see a question in there about community CBOs, so community benefit organizations, delivering kind of those social service types of services to patient potentially in their home. When you think about that caregiver opportunity, I know Pauline mentioned, for example, guide and caregiver support's a big part of this, but what are those other kind of short-term, those near-term opportunities you see to kind of build that caregiver thread into the home-based setting?
Yeah, I think a similar, similar needs in terms of continuing efforts around payment reform that better recognizes and integrates or creates incentives to integrate the caregiver into care teams. So Pauline highlighted the development of introduction of caregiver training services reimbursement codes, right? Addressing the longstanding gap that I mentioned between the roles of family caregivers that they're navigating within in-home health, and then the kinds of supports that they get from healthcare providers and systems. This was a really positive development that a lot of advocates have been championing over the last several years. And the introduction earlier this year was really critical in sending a strong message that the work of family caregivers is valuable and that it could be improved upon with training and support from a healthcare provider, particularly as folks are navigating complex care situations. And that's been a key development. So the physician fee schedule that'll be finalized for 2025 will expand those caregiver training service codes to include direct care or support and training for medical and nursing tasks, looking beyond training related to activities of daily living, which are critical, but again, recognizing the full breadth of the kinds of supports and services that family caregivers are assisting with, making sure that those are able to be provided, at least provisionally, through telehealth, right? Ensuring access for working caregivers and caregivers in rural communities, which face a lot of barriers to care. And then additionally, the home health perspective payment rule for 2025 emphasized the need to identify family caregivers and social determinants of health screenings. Yet there's lots of barriers that we can continue to address, and then also opportunities. So Guide is a great example of an exciting model that is really looking at how to innovate caregiver support and integrate caregiver support and training and investing in the caregiver as part of patient care. So paying for things like respite services, paying for things like education and training, and then evaluating the impact from a quality perspective based off of the caregiver experience is a really innovative and positive step in the right direction. What we'd like to see is once we start learning the impact of the Guide approach, how do we take that and scale it and apply it to other complex care areas where we know caregivers are just as essential to rare disease care or cancer care as they are to dementia care. So there's be a lot of, I think, exciting opportunities to take learnings from Guide and apply to other complex care areas from a reimbursement perspective.
I think that is a perfect segue into kind of where we want to focus a lot of the time at the end on, learnings and kind of scaling those bright spots more nationally, scaling those bright spots into other programs. And Pauline, CMS has done this really well. We see this not just through Guide and not just through Reach and everything, but we also see it to what you were saying earlier about what you're doing in the fee schedule in terms of supporting those near-term opportunities to immediately support providers. And even if it's not home-based care, getting them to home-based care in the end. And so would love to hear from you exactly what Jason was saying. What are those kind of key learnings so far? You hit on a couple earlier on, but especially through Reach, we just saw the performance data come out. Things look great, and there's probably a lot of interesting things you guys are learning from it. So would love to hear from you about what are those maybe 2 or 3 key takeaways you have.
Sure. So I think, the evaluation results that we got suggest some really promising results. Well, mixed also, we're seeing that high needs reach ACOs, reduced gross expenditures. We are seeing that they've had some improvements in quality that are statistically significant around, lowering all-cause readmissions and hospitalizations for ambulatory care sensitive conditions. The target audience of the, the beneficiaries, I mean, they had on average 12 chronic conditions. I mean, that's just enormous. More than 2/3 were dually eligible for Medicare and Medicaid, and over 1/3 were representative of diverse communities. So we're really seeing some promise in terms of the types of patients that are being served. In terms of the strategies, we know that the payment model, in terms of moving off of a visit-based fee-for-service payment model, is really where we need to be in terms of providing that population-based payment mechanism combined with some level of accountability with downside risk, an opportunity for shared savings. I think these are things Tom said earlier, really are helpful for supporting team-based care. We have seen interdisciplinary care teams being used in our high needs reach participants, with nurse practitioners, social worker, going in to provide home-based primary care. Some only do home-based primary care. Some of my staff actually got to do some visits and had the opportunity to actually witness what that looked like. It was really informative as we think about the future. Other, I think, high-value features include remote patient monitoring, given some of the workforce shortages, and we know some folks are using that as well. Thinking about extended hours, so that it's not just the 9 to 5, but you can find some provider, some clinician able to provide help and support when needed. I think these are all really important strategies as we think about the future, and that we're thinking about as we contemplate what comes after REACH, which ends at the end of 2026. One other point that I want to mention is we've also learned from advanced primary care models and are trying to figure out how to build from those learnings into the Medicare physician fee schedule. So the fee schedule this year included the advanced primary care management codes. And I think what's important to mention there is, they're adjusted based on, some acuity of, in terms of how we pay for those codes. And I think that's a really important step into recognizing that there are differences and needs for greater support for certain types of beneficiaries.
Yeah, and that's, I think, really important to acknowledge, and connecting it back to Tom, and I'm going to come to you in a second, Tom, that there's a spectrum of services or model opportunities of learnings out there that is reflective of what you were saying, that no one model can kind of work for every patient. Every patient is very unique. Again, I'm reminded of some of the patients, my previous experience at Baylor Scott and White, where there were complex patients that are had multiple comorbidities, but there are also patients who are polypharma with 30+ medications, who have very, very serious illnesses on top of very, very serious illnesses. And so providing the flexibility in terms of a payment model or even a program where the provider can kind of tune up or down the services that are needed for the patient to meet their needs where they're at. Would love to hear from you. As Pauline mentioned, you're an ACO REACH high needs participant. What are some of those lessons that could kind of inform those short-term policy opportunities to continue to build on those lessons learned that we were just discussing, to kind of improve the access for longitudinal care in the home and community-based setting? Are those learnings from your organizations opportunities for us to build on in Bill's payer world, or are there opportunities for caregivers and Jason's? Like, what are those kind of key learnings that you're seeing from a high needs participant?
No, thanks, Frank. And I think it's an excellent question about where we need to think about the areas that really are changing the way that we think about investing in healthcare dollars. And when we thought about fee for service, we had a very limited structure. It's given to you. You have a very limited margin contribution. You can't deliver care outside of this kind of very limited, basically fee for service structure, for lack of a better word. When we think about accountable models, it allows us to start investing into things that really are never possible under fee-for-service. To Pauline's point, we have an on-demand service 7 days a week where somebody needs a house call. They can call and get one of our providers to come out and see them. It's impossible to do that under fee-for-service because the opportunity cost of having somebody sit there and wait and maybe get a call and maybe not. We would have to give that person a full schedule and make sure they were highly productive. Where in an accountable model, we can literally wait for that patient to be sick and be able to respond to those care needs so much faster. It's a similar story around like behavioral health. It's almost impossible to build a full behavioral health care team, but in an accountable model, you can do it. Same thing with our wound care teams. Care management is far more robust and interdisciplinary as a result of the accountable relationship. And it's the reinvesting of the return, saying that, hey, we did really good job this year, but we noticed in some of the data and analytics that we could do even a better job if we made some of these investments around these care services or gaps that were not really filled under the fee-for-service structure. It produces a positive momentum where there's some cycles to that, where you can continue to reinvest and to continue to reduce cost, increase services. And we're still very much in that phase as an industry. I think this is the first time we've really seen the ability to do that. And there's quite a few successful high needs reach ACOs that are really figuring this out today. But there's some of the less stuff behind the scenes, like the more technical aspects. We need data and technology. We've never really had the data before. Now we have all this data. How do we turn information to be able to make the right care at the right time at the right place for that patient? Like, we need that kind of translation. So as an ACO or high needs participant, you're now responsible for receiving all of the information, but turning it into actionable insights is another really thing that we have to think about. As far as policy recommendations, I think there's a few things we need to think about. And first, I would say that, to Pauline's point earlier, I think just building on the success of the High Needs Reach ACO is the number one. It's purpose-built for high needs patients. We need accountable relationships in this type of work. And I think building on the work that's been done there before and tweaking that is really something that needs to happen for the field. And I think there's a couple of fee-for-service or Medicare physician fee schedule tweaks that we can make as well. Kind of site-neutral payment sounds like something that we talk about for hospitals, but for home-based primary care, the place of service for a lot of the work we do is reimbursed at a substantially lower rate than the same work would be done in a hospital. And it makes or in an office. And it makes no sense, because really we have all this travel time. We got to go to a home, we got to set up computers and deal with, wireless connections. So we need at least on par reimbursement for the work we're doing. I'd say to another point around Pauline's about the advanced care management, primary care management payments. These risk stratified payments we see as a real opportunity, because they're kind of like right in between fee for service and the step towards accountable care. It allows people an upfront ability to kind of get some care management dollars, to invest them in a way without a lot of risk, but to invest them in a way that they think is going to produce the most return for those patients, whether that's nursing, social work, other types of care management activities. We're highly supportive of that. The only thing that we would like to see adjusted is maybe to have another tier that's more representative of the complexity of the patients that we serve. The average patients in high needs reach ACO like this at 12 medicines and 7 or 8 chronic conditions. And the highest tier currently for the APCM codes has got 2 or more chronic conditions. And so it's just a little bit missized for the complexity of the population that we serve.
Yeah, Jason, maybe turning to you real quick. I think a key theme I hear there is the path we're on is a good one. There are payment supports that are working to help meet the needs of patients. I'm curious a little bit about what are those policy opportunities to meet the needs of caregivers. I think you talked a little bit about educational supports, for example, making sure that we can meet the needs of caregivers in terms of making sure they feel comfortable addressing the needs of their family or their friends, whomever they're caring for in the home. But would love to hear from you about maybe beyond the payment necessary to kind of support the infrastructure and those kind of foundational items to support caregivers. What are those other levers we got to be thinking about from a policy perspective to better recognize and support caregivers and ensuring equitable access to them?
Yeah, I think a couple of thoughts. One is ensuring that the investments we're making around payment reform and new reimbursement opportunities for providers to train family caregivers are fully utilized. Right, these are only good if providers are actually utilizing these new codes and offering training to family caregivers. So we've been championing the importance of the development of learning communities. We just released some research that looked at transplant caregiving, which is an area of the health system where caregivers in the vast majority of transplantations are required, our families are, as in turn, need to be eligible for transplant, need to identify a family caregiver or a caregiver to be part of the care team in the vast majority of transplantation cases. So we surveyed transplant centers asking a number of things, but one of the things we asked about, are you aware of these new reimbursement codes? And we heard 80% were aware, but only 7% were actively in the process of utilizing these codes. Now they're relatively new and they're expanding at a good pace, which is good. But I think we need to do more to ensure that those codes are utilized. So I think that's key. Second is taking that same approach of incentivizing providers and investing in providers and investing in caregivers. So thinking about what assessment looks like, assessing the needs of caregivers to understand that, do they need more training? Do they need respite? Do they need social service supports that are going to translate into better care for their care partners, but then also better enabling them to provide care sustainably? So more rigorous and standardized use of assessments from a caregiver perspective is going to be really critical. The CTS moves us in that direction. But then I think also taking a page out of Medicaid's book, when it comes to creating pathways to financially invest in family caregivers. We see this through consumer direction. This is something that happened, blossomed during the pandemic with public health emergency dollars as more states had flexibilities to invest in family caregivers and compensate family caregivers for the care that they provide. We know that's possible through Medicare and the in-home health benefit, but it's much more, there are many more barriers to access. So thinking about the role that CMMI can play in testing and evaluating mechanisms to enable family caregivers through the Medicare program to serve the role of a compensated family caregiver, I think is another step in the right direction in terms of valuing, investing, and improving care for families navigating complex conditions.
Yeah, thank you, Jason. I think when we think about learnings, and we've said it a couple times, I think assessments and kind of the rapid transfusion, the rapid diffusion of what's working and not is really important. Bill, turning to you before we kind of close things out with a final question. Policy levers from a non-CMS payer perspective. We see things like REACH and the fee schedule that are working in the landscape. You guys have turned on some of these things yourselves. Would love to hear from you about what else needs to be turned on. What are those additional innovations that are kind of needed to really spur, from your perspective as a payer, this home-based medical ecosystem? Are there similar things that you're seeing in terms of payment supports and the need for evaluation, or kind of what are your thinkings on what are those near-term opportunities and levers that need to be pulled?
Yeah, I think from a payer perspective and MA player, we see similar things that the rest of the panels talked about, but also can appreciate the work that CMS and the Innovation Center have done driving these models. Now that they're out there, we have providers that are looking to us to say, we're ready for this, where other times it used to be, we're comfortable in a fee-for-service world, but the ones that are successful in the ACO REACH programs or some of the advanced primary care programs are now looking to us for similar models, and we're happy to oblige that because they have the outcomes and they're able to show the value there. And they're kind of ready to manage that with those extra resources that they have, and we can provide similar resources to help them have that shift. I still go back to, I think, one of the policy changes that we'd like to see or think about is how do we bring the rest of the ecosystem along with this? So if you're paying accountable care in one part of the ecosystem, but it's fee-for-service downstream or upstream of that, you're still not completely aligned to the entire spectrum of the care continuum. So we certainly have flexibility as an MA plan to do some of that, but certainly see as CMS can push that across the ecosystem, we could do more of it as well.
Yeah. And I know we have a lot of questions in the chat. I don't know if we'll have time to get to them, but I want to close out with not necessarily a question, but obviously in an hour webinar, there are things we're not going to be able to address. This is a really complex population, a complex model, and I think there's been a lot of progress to date that we've highlighted, not just from CMS and MA plans, healthcare organizations, caregivers, but I think there's just a lot of interest in scaling these. But again, we can't do it all in a day. We can't do it all in an hour. So turning to each of you, maybe Jason, I start with you. What's something we necessarily haven't discussed today that's top of mind for you in terms of not just a near-term opportunity or challenge, but something that is perhaps a little bit necessary that we need to at least give voice to or be cognizant of when we think about scaling home-based care and this kind of medical ecosystem, this spectrum of services that's out there to meet the needs of various patients. So Jason, turning to you, what's that one thing that we haven't discussed today that we do need to be cognizant of, though?
Yeah, I think aligned with what we've been talking about. We haven't talked about it much. I know Ronnie brought it up as sort of the hospital at home trend and a lot of enthusiasm from the policymaker perspective to keep that up. But I think there's again a really urgent need for considering the family caregiver and the design, and especially if we're thinking about making this a permanent solution. So I think that is critical. And then last is sort of the where cultural and equity fits into this, from particularly from a race ethnicity perspective, thinking about cultural competency as we develop these supports, but then also the rural-urban divide, I think, is really critical, and where there's a lot of promise here, but we see a lot of distinct barriers of caregivers in rural communities who are experiencing higher levels of distress, inadequate access to support services. How are we thinking and designing supports with these folks in mind?
And Tom, maybe I go to you next. What's that kind of one thing we haven't discussed today that you think needs to be top of mind and mentioned today? Oh, I think you're on mute.
Sorry about that. I would say that the one thing would be around the fact that the field is really, we have to meet them where they're at today. We heard it a few times that it's a very fragmented field with a lot of small practices, sometimes serving their urban or rural communities. And we need payment methodologies that support all types of practices. It can't just be for the large ACO type practices like mine. We can't get everywhere fast enough. And so we really need something that is much more broad for the field and has a Medicare physician fee schedule component that allows practices to be successful while they're still in that world and maybe they never get out. And then all the ones that kind of help them transition to sustainable ACO models. And I would say even those practices are generally smaller than we might see in like an MSSP. So generally, like these high needs practices are going to be less than the 10,000 patient number, so to speak.
That's really important for us to recognize, absolutely, that not all providers are the same, not all patients are the same. Bill, turning to you, what's one thing that necessarily we haven't discussed today that you feel like we really need to have mentioned today?
I think one last thing that we haven't touched on much and goes back a little bit to the population, but is how are we being proactive in serving this population? A lot of what we do today is reactive and it's post-institutional care. So how do we identify these members and patients earlier? How do we align them to the right services? I think really that's one of the big opportunities, again, making sure we're proactive and not reactive.
Well said. And closing out with CMS, Pauline, what's one thing that necessarily we haven't discussed today that's top of mind for you and your colleagues at CMS?
I think I'll speak just from, sitting in the Innovation Center where we have, a statutory authority around expansion and scaling of a model if it meets certain statutory requirements around improving quality and either being budget neutral or having savings and improving quality. So I think that's in some ways top of mind for me is how to design a payment model that can achieve what we need to achieve from a statutory perspective, so that we can make these kinds of programs permanent features of the Medicare program.
Great. So I know we're out of time today. I just want to thank all the participants, Tom, Jason, Bill, Pauline. This is a really rich discussion. I think the audience really enjoyed it. I know I learned a lot about home-based primary care and really just appreciate the comments, not just today, but again, your engagement over the life of this project and looking forward to next year as we kind of wrap things up. Welcome you guys to go off camera, but really just also want to thank the audience today for joining us. I think we've heard a lot of different things today, but picking up on maybe where Bill left off, which is there's a spectrum of patients and there's also a spectrum of providers, or sorry, I believe Tom was saying that there's a spectrum of patients, but there's also a spectrum of providers, that there are kind of to what Jason was saying, there's cultural, there's rural barriers, and there's a need to meet everyone kind of where they're at, including caregivers, that there's this team environment that is really important to these homebound older adults that is just getting going. And we need to really emphasize that it's a team-based approach and that to scale this perhaps in the near term, we're going to be having to do a lot of testing and evaluation of these different mechanisms, not just for caregivers and what's working, but overall, kind of what is the model that seems to be working the best for these different populations to meet their needs. Finally, I think we heard a lot about the need for payment to support all this, that if we're going to be successful in scaling these models nationally, while we see a lot of bright spots, both in the fee schedule, both in what MA plans are doing, but also in REACH and other innovative models like Guide, that we'll need to probably think hard about what are those payment models necessary to support providers, not just scaling what they already have, but also just the foundational elements of building what providers some don't have. So really want to thank you all for participating in this panel and thank the audience for listening in today. The recording will be uploaded on the project page to the Duke Margolis website in the coming weeks. So encourage everyone to make sure that you come back and look for the recording. I also want to thank everyone involved in making sure that today was a success, not just only our panelists, but also Montgomery Smith, who's been really instrumental in leading this work, Ingo Morken, who's the policy research assistant supporting a lot of the on-the-grounds research, Mark and Rob for their leadership, and obviously Hartford and Ronnie for their support for this project over many years and looking for a collaborative relationship going forward. Finally, I'd like to say that we'll be sharing beyond the link for this webinar and the recording for it. We do have a home-based primary care newsletter. We have an issue of that coming out in December, so that'll be out in the next couple of weeks as well. Again, thank you all for joining us today. Hope you enjoyed the conversation and looking forward to another one in the future. Thank you. Have a great day.